The director will focus, as I was saying, our briefing today on the COVID situation. As we are aware, the pandemic is still on. So the director will focus on the epi situation of COVID and, of course, highlight other public health outbreaks that are ongoing across the continent, including the Ebola crisis right now in Uganda. Our usual medium to be a part of the Q&A section. One, you use our regular WhatsApp number, +251 94550 2310. Let me read that again, +251 94550 2310. And of course, you can use the Zoom platform, the Q&A section on the Zoom platform, as well as you can raise your hand using the raise hand icon and you can come to us live. So without much time wasted, let me introduce you to our acting director, Dr. Ahmed Ogwe-Oman, who will lead us in the briefing for this afternoon. Director, it's over to you for the briefing. Thank you.
Let me start by apologizing for the delay due to other commitments that we could not be able to move. Today we'll structure the briefing into three parts. First, we'll start with COVID, then we will go to other public health events of significance, and then after that, we will do some general announcements in relation to our work here at Africa CDC. So I'll begin with the COVID update for today. And the total number of cases that we have documented on the continent since the beginning of the pandemic is just over 12 million cases, which accounts for 2% of the total number of cases of COVID-19 that have been reported globally. We have also seen recoveries here on the continent of 11.4 million, which translates to 95% of all the cases that have been confirmed here in Africa. We have lost just over 255,000 people due to COVID, and the cumulative case fatality rate is 2.1%, which accounts for 4.1% of the global deaths due to COVID. Our case fatality rate of 2.1% is higher than the global average of 1.1%. Looking at all the figures from the beginning of the pandemic, these 5 countries have experienced the largest burden of COVID. South Africa with 33% of the cases here on the continent, Morocco 10%, Tunisia 9%, Egypt and Libya each with 4%. When we look at the epidemiological week 40, which is running between the 3rd and the 9th of October, and then we compare it with epidemiological week 39, this is what we see. The number of new cases during this Epi week 40 is 6,279, which is a 15% increase when compared to the previous week. The highest proportion of these new cases are and Northern Africa region with 6%. The number of new deaths during Epi week 40 is a total of 21, and this is a 60% decrease, 60% decrease in the number of deaths when we compare it to Epi week 39. When we analyze it over a period of 4 weeks, we see that the trend of new cases has shown a 10% increase when we look at the 4-week period. The increases have come from eastern, central, and southern regions, while decreases have been seen in northern and western regions. But overall, the period of 4 weeks, we have seen a 10% increase across the continent. During the same period of 4 weeks, when we look at new deaths, we see that there has been an overall 2% average increase in the new deaths, and the increases have been seen largely in northern, southern, and western Africa regions, with decreases being recorded in eastern and no change in the Central Africa region. So for new deaths over the last 4 weeks, we have seen a 2% average increase. For vaccination, COVID-19 vaccination, when we look at the continent as of the 12th of October, the total number of vaccines that have been supplied are 997 million to 54 of our member states. The total number that has been administered so far is 717. That is 717 million doses, which accounts for 72% of the total supplies to the continent. The coverage of those who are fully vaccinated is 23.2% currently, and boosters stand at 2.8%. When we analyze the vaccination on the continent, this is what we see. That when we look at AP week 40, 15 countries have indicated increased vaccination rates compared to the previous week, while 7 countries have indicated a decrease in vaccination rates compared to the previous week. We attribute the increase in vaccination rates to the sustained campaign, the mass campaigns that we are holding across the continent, and also better availability of vaccines at the points of vaccination where mass campaigns are not being conducted. We are, however, seeing some challenges with the numbers of people being vaccinated due to competing priorities, including other outbreaks like polio, yellow fever, measles, cholera, even Ebola. And we are also seeing that the systems are being stretched when you have the same health workers going out for the mass vaccination campaigns. We are working with our member states to ensure that this period of mass vaccination campaigns do not affect the provision of healthcare services for the routine work that healthcare workers do. We are therefore recommending to our member states to do the following to increase vaccination rate. Where appropriate, to integrate COVID-19 vaccinations with other interventions, including other vaccination campaigns, to improve collection and management of data so that we have accurate figures of those who are being vaccinated, to improve access to vaccines through door-to-door campaign and mass vaccination campaigns across each and every country, and also to pay close attention to the youth, because this is the majority within our continent. So targeted mass campaigns that are aimed at the youth, we are recommending that. When we look at deliveries that we are doing as Africa CDC, the Africa Union, through the AVAT mechanism, over the last week, we have delivered additional Johnson & Johnson vaccines to Liberia, Nigeria, Sierra Leone, Malawi, and Central Africa Republic. These additional doses of vaccines are designed to support the mass vaccination campaigns that we are conducting through the Saving Lives and Livelihoods initiative. To date, we have supplied 99.4 million doses of Johnson & Johnson vaccines that have been delivered to 36 of our member states. And of the 99.4 million, what we have facilitated, that we have facilitated, 72.8 million comes from the Africa Union mechanism, where member states have been paying for these vaccines. The Saving Lives and Livelihoods program, supported by the MasterCard Foundation, has procured so far 19.2 million doses, and the US government donated 7.3 million doses of the Johnson & Johnson vaccines for use on the continent. So this is the situation with COVID-19. Let's move now to other public health events of concern on the continent. We are currently closely following up 10 different events. Today, I will share some details of 4, while the other 6 we are monitoring from a distance. And let me start by letting you know which the 10 are. First, and this is a new event, is the diethylene glycol and ethylene glycol poisoning in the Gambia. To make it simpler, this is the cough syrup that has caused deaths in the Gambia, Ebola virus disease outbreak in Uganda, wild polio virus outbreak in Mozambique, and the multi-country monkeypox outbreak across the continent. So these are the 4 that I will give you some details about. The other 6 that we are still following up are the Rift Valley fever in Mauritania, West Nile virus outbreak in Tunisia, the multi-country Lassa fever outbreak on the continent, measles, again, this is a multi-country outbreak, cholera, another multi-country outbreak, and Crimean Congo hemorrhagic fever in South Africa at the moment. So I will speak to 4 of these and give you some detail. The cough syrup poisoning in the Gambia is a new public health event on the continent. And on the 5th of October, the Gambian Ministry of Health reported that about 78 individuals had been affected and resulted in 66 deaths, giving us a case fatality rate very high of 85%. And this was the result of acute kidney injury amongst children roughly between 5 months and 7 years from across Gambia as a country. All of them, the 78, had a history of being administered this particular cough syrup that had been imported from one of the countries that supplies medical products to African countries. When toxicology assessments was done of the different samples of cough syrups that had caused these deaths, it was confirmed that those cough syrups had diethylene glycol and ethylene glycol. These are contaminants which are known to be toxic and often potentially fatal. So far, only Gambia has reported this particular effect on those who are consuming cough syrup. The Gambian Ministry of Health established very quickly an emergency response plan, and all the cough syrups in question were recalled, tested, so as to develop an understanding of how broad this contamination was for products that were on the shelves. Africa CDC, when we were informed, we have been working with Gambia and the country of origin, to be sure that no other country would have contaminated batches of this particular cough syrup. The second is Ebola virus disease in Uganda. Since the last brief, 10 new confirmed cases and 9 new deaths have been documented. And this is a 47.3% decrease in the number of new confirmed cases compared to the last briefing. I must add here that the government of Uganda has recently adjusted the reporting to only those cases that have been confirmed. The reason being that testing capacity has improved, and therefore it is important that we provide specific and accurate information about cases that have been confirmed. Cumulatively, 54 cases have been confirmed with 39 deaths, and of the 39 deaths, 19 are confirmed cases, and the others are probable because they passed away at a time that swabs could not be able to be taken for confirmation. So the case fatality rate so far is 35% across 5 districts of Uganda. Of the total number of confirmed cases, 10 are health workers, and unfortunately we have lost 4 health workers thus far. The good news also is that 14 individuals have recovered and are being reintegrated back into their communities, and these 14 include 5 health workers. In addition, 1,123 contacts are now being monitored, and 432, which is 38%, have completed their 21 days follow-up and have been released and reintegrated back into the community. The number of those who are being followed up has actually increased by 30% compared to our previous briefing, meaning that contact tracing has improved, and cooperation from members of the public has also improved. The Ministry of Health in Uganda is very actively, through its Emergency Operations Center, engaging with communities, strengthening the healthcare system around the affected districts, providing risk communication and community engagement beyond the area where there is the epicenter, and with support from partners, including ourselves, we are expanding this support, the communication and the engagement with the communities beyond the affected areas, indeed into the neighboring countries as well. We as Africa CDC, apart from activating our own Emergency Operations Center here in Addis Ababa and our Nairobi office as well, we have deployed teams of experts to support the Ugandan response, and indeed we continue to train health workers on the ground on infection prevention and control, on case management, and particularly on contact tracing and community engagement to ensure that all relevant individuals and influencers of the communities have been provided with the right information to be able to secure those who may be exposed and limit transmission beyond the epicenters. The third is wild poliovirus in Mozambique. On the 5th of October, the Ministry of Health of Mozambique reported 1 case of wild poliovirus type 1 in one of the provinces of the country, and to date, 7 cases have been reported from that particular province. The Ministry of Health, with support from Africa CDC and other partners, have intensified polio surveillance activities across the country, with focus, of course, on the province that was affected. Finally is the multi-country monkeypox outbreak. Since the last briefing, 14, that is 14 new confirmed cases have been reported from Cameroon 1, Ghana 12, and Mozambique 1. This is a 62.5% increase in the number of new confirmed cases when compared to the last briefing. Cumulatively, since the beginning of this year, we have documented 5,826 cases, including 717 that are confirmed and 5,110 that are suspected. Unfortunately, we have lost 155 individuals, giving us a case fatality rate for monkeypox across Africa of 2.7%. And all this has happened in 13, that is 1/3 of our member states on the continent. As Africa CDC, we continue to work with our member states that are affected, we have increased our supply of laboratory test kits so that we can confirm as many of the suspected cases as possible. We are training laboratory technicians as well in laboratory diagnosis of monkeypox. We are also sequencing samples to be sure that we are not seeing any variants or any new strains. We have also strengthened capacity for disease surveillance, particularly amongst communities where the epicenter was, and we continue to mobilize to discuss with our partners on vaccines for addressing monkeypox. These are the 4 outbreaks that I wanted to share with you today, but as I said, the other 6 we are still continuing with monitoring, and when necessary, we shall be able to provide you with more information regarding those other outbreaks. Beyond public health events, during the 4th and 6th of October, Africa CDC held a training for public broadcasting entities or in West Africa. We held this in Benin, in Cotonou, in Benin, and we provided training to these journalists on how to identify information that is not correct, how to address infodemics, how to use the health data that we release in a way that can be able to help and support public health interventions on the continent. It was very well received, and there's requests for more to happen in other parts of the continent, and we shall continue to do that. On the 10th of October, we commemorated the World Mental Health Day, and considering the type of work that we are in, emergencies all the time, this year's World Mental Health Day was particularly important, particularly the theme of make mental health a global priority for all. We as Africa CDC have made mental health a priority, and we are putting in place programs for our staff and the staff of the Africa Union in general to provide psychosocial support when necessary. Thirdly, on the 12th of October, which is yesterday, the government of Uganda hosted a high-level emergency ministerial meeting on cross-border emergency preparedness and response with support from ourselves as Africa CDC and the World Health Organization's Regional Office for Africa. We had 11 countries represented at ministerial level, and after the whole day's discussion, a communique was issued, which you will see on our website. We've also issued a press release to go with it. And the 3 key agreements that were made at this meeting are: 1, the ministers decided to set up an Africa Ebola Coordination Task Force, AFECT. And the reason for setting up this task force is to mirror what we did with COVID, so that we can be able to have information flowing quickly across the continent, and also standardize the way in which we prepare and respond to Ebola outbreaks. We want to be sure that every country that is at risk is well prepared, just in case they may be able to document a case of Ebola. Secondly, is the ministers agreed to develop a framework for collaboration and coordination, particularly on cross-border emergencies. And this goes beyond Ebola, but we'll use Ebola as the prototype as we develop this particular framework. Finally, is the ministers have also agreed to hold a follow-up meeting by the end of November so that progress on where we are with the first two items can be able to be assessed. And this is now going to go beyond the Eastern Africa region. We are going to do it for the whole continent. So it was a very, very important, productive meeting with ministers sitting in and providing us with the very key guidance and wisdom on what we should be doing going forward. Fourth and last is, as we speak, from Tuesday, we've been hosting here in Addis Ababa a high-level meeting on community health, where we were disseminating the results of a survey on Africa's preparedness in as far as community health workers are concerned. And the intention was to generate action out of that survey so that we can be able to have our member states strengthening community health workforce across the continent, strengthening the support mechanisms for community health workers, and also ensuring that we standardize the way in which we train and deploy community health workers. That meeting has closed today with very good results and a clear call to action as well. So these are the key things that I wanted to share today. And Nick, happy to go into questions and answers. Thank you.
Thank you, Director, very much for the very comprehensive overview of disease outbreaks happening on the continent, and of course, the works of Africa CDC in implementing its mandate as enshrined in the statute. Let me also emphasize the last note on which the Director ended the briefing, that is the issue with community health workforce. And as we all know, through the Africa CDC new public health order, strengthening and empowering continental health workforce is a priority and a key priority under that new public health order. So colleagues, we will now move into the question and answer section. This one is the interaction with the journalist asking your question to the Director, and he will be providing adequate responses. So we've already begun, but before we begin the first question, let me remind you of the medium through which you can send your questions. First, you can use our WhatsApp number, the usual one, +251 94550 2310. Let me read that again, +251 94550 2310. Or better still, you can use the Zoom platform in the question and answer section, or better still, raise your hand and we will give you the opportunity to speak and ask your questions. So we've got two questions so far in the Q&A section. Let me move to that quickly. The first question is from one of our regular colleagues, Judith Akodo, who is with the Kenyan Broadcasting Corporation. Akolo says, my question is, could a rise in zoonotic diseases be as a result of the consumption of bushmeat? What can be done to contain this? That's Judith's Akodo question. Over to you, Director.
No, thank you, Judith. And it is a fact that many of these pathogens, particularly the viruses that are currently causing many outbreaks on the continent, are the normal habitat is in wild animals and bats. To zero in on bushmeat only will be a very small portion of the risk that engaging with the wild environment poses to us as human beings. But because the pathogens that are causing these outbreaks are naturally found within the wild animal and wild bird kingdoms. It means that the way that we engage with nature needs to be addressed. The ways that we can be able to do this, one is information. We need to package and provide information to our members of the public so that they appreciate and understand the risk of engaging with wild animals and wild birds. This needs to be done in a respectful way so as not to offend culture, but to provide information that is going to provide to afford these communities safety rather than exposing them to virus. So one is information. Second is we need to engage with our surveillance mechanisms in a very sustained manner, meaning that our community health workers, for example, who are part of the communities, need to be not just trained and deployed, but we also need to support them so that any small activity, the very first case that appears in the community, we are able to identify and react quickly, because this then protects the community while showing the example that engaging with the wild would result in a very high risk of contracting some of these pathogens. Finally is for situations where it involves culture, it means that we need to provide alternative to that particular cultural practice. In this way, you get the community to come along rather than to make it difficult for communities to practice culture without information. So these are the three things, Judith, that I would say we need to do so as to reduce the risk of human wild conflict, which then results in importation into the human population of these pathogens that are currently causing the outbreaks we are seeing. Thank you.
Thank you, Director. Very clear answer. Let's move on to our second question. Remember, as we're taking our questions and answer, you can use our regular WhatsApp number +251 94 2310. Use either of the Zoom icons. That's the question and answer, or raise your hand and you can ask your question. Our second question comes from our colleague Alexander Winnie. Winnie is also a regular on this briefing, doing the regular Thursday weekly briefing. Winnie has two questions, so let me begin with the first one. He said, "Good afternoon, Winnie Alexander from Reuters." The first question says, "Does the Africa CDC believe there is an undercut in its data of monkeypox cases in Africa, given the difficulties of reporting cases in often hard-to-reach areas? Are efforts underway to improve detection?" That's Winnie's first question. Let me let you answer that, then I will ask the second one. Over to you, Director.
No, thanks, Nick, and thank you, Winnie. Underreporting is always a risk when you have a condition like monkeypox that is affecting communities that do not have access to regular health services. So there's always that risk. At the moment, we do not believe that it is a very big difference, what we are documenting and what may be not documented yet. We don't believe that there's a very big difference. It is very representative of the situation on the ground. And what we are doing to ensure that it is representative is through identification, contact tracing, and community engagement, so that they are able to bring those who have been affected to health facilities for proper management. So we do not believe that there is a significant difference between what is being documented and what may be additional cases at the community level.
Thank you. Let's move to Winnie's second question. It has a little note, so let me read clearer. At the height of the COVID pandemic, there was a big push for vaccine manufacturing on the African continent. But Aspen Pharmaceutical in South Africa has still not received orders for its COVID vaccine production lines. What are the prospects for Aspen's COVID lines? Is the Africa CDC still pushing for orders to be made? And more broadly, what are the prospects for vaccine manufacturing in Africa if plants like Aspen's can get orders despite the efforts of Africa CDC, South African government, and others?
No, thank you. Thank you, Winnie, for that second question. Currently, the enterprise of vaccines manufacturing on the continent is not limited to COVID-19 vaccines manufacturing only. This was the catalyst for us as a continent to make that decision that we needed to come from 1% to 60% manufacturing by 2040, local manufacturing by 2040. So it's very important to bear that in mind, that the whole enterprise of vaccine manufacturing, the market is big and it is present. What we need to do is organize that market in a way that enables purchase of all these vaccines in an organized way. So we have good quality vaccines being manufactured, and then they enter the market of Africa. So this is a big enterprise across many priority diseases. We've identified at least 22 of them. Now, in as far as prospects are concerned, there are certain realities that we have to deal with on the continent. And the first is that the majority of the vaccines that we use are purchased through international mechanisms. And those international mechanisms have traditionally been purchasing these vaccines, most of the vaccines, 99%, outside of the continent, meaning that we need to ensure that our African manufacturers are actually getting into the supplier track when it comes to the majority of the vaccines that are being purchased through international mechanisms. Which brings me to the question about Aspen. We continue to engage with those who buy vaccines. The big challenge right now is that we have a bit of a glut of COVID-19 vaccines. And in this way, purchase becomes the second step rather than the first one, when you have enough and they're not moving fast enough. That is why also we have put the Saving Lives, Livelihoods initiative, so that we can be able to get as many vaccines into arms as possible and then create a space for purchase of new vaccines. So the Aspen experience teaches us two very important lessons. One is we must secure the African market for African manufacturers first. And our heads of states already made a clear pronouncement in May that all international purchasing mechanisms need to purchase at least 30% of what they're purchasing from the continent of Africa, because this is how the vaccines manufacturing enterprise will grow and become stronger for African manufacturers. The second thing that we need to do is to make sure that the infrastructure, the environment for manufacturing vaccines on the continent is appropriate. And this includes getting regulatory mechanisms here on the continent to be functioning properly, getting the continental coordination for regulations also to be in place. And that is why we have the Africa Medicines Agency And thirdly, we need to ensure that our member states, those who have the capacity, ability, and are in the category where they purchase their own vaccines, to be linked to the vaccines manufacturers here on the continent. And as Africa CDC, we are doing that. We expect that Africa Medicines Agency, when it begins functioning fully, it will also continue to do exactly the same. So we have not given up on the case of Aspen. We are getting vaccines into people's arms, creating space, and then creating an opportunity for us to purchase from Aspen in the near future. But the whole enterprise of vaccines manufacturing, at least 22 vaccines amenable diseases have been identified, and we want all of these to be manufactured on the continent by different facilities here in Africa. Thank you, Winnie.
Thank you, Director, and thanks to our colleagues, Alexander Winning and that of Judith Akoda. Looking through all of our different screens for questions, I don't see anyone coming in. So colleagues, it means we have got to push to the section where the Director will give us his final two or three main points, headline points for this week briefing. So Director, it's over to you, and after that we'll close for this section. Over.
No, thank you. Thank you very much, Nick. And my three messages today, number one is on COVID-19 vaccination. We have picked momentum. We are in double the countries we were in 1 month ago, and we will be in double the countries 1 month from today. And as we pick that momentum for COVID-19 vaccination, we ask that you as journalists, you as members of the public, you really carry that message that we need to get vaccinated, the young, the old, and everybody else in the middle. So vaccines are available. Let's go out and get them. Vaccines for COVID-19. The second message I have is on Ebola, particularly the outbreak in Uganda. We have made our assessments that two very important points with this outbreak is that we know how to deal with the virus. And therefore, the presence of the virus is not the biggest problem. The biggest problem is when we allow that virus to circulate within the community. Therefore, for Ebola virus disease, we have put in place an agreement with the relevant health ministers of how to handle any case so that it does not circulate. The virus will always be there, but we need to limit its ability to circulate within the population. We have also agreed that there will be no closure of borders or heavy restrictions of movement, because this has effects that can be very negative in the long run for our work around health emergencies. So Ebola virus disease is there. We have mechanisms to be able to limit its circulation within the population, and we have the capacity to be able to limit its spread within a country and beyond. Third message I have today is on local manufacturing. We as Africa CDC have been clearly instructed by our heads of state that we need to get manufacturing on the continent happening, not just for vaccines, but also for diagnostics, therapeutics, and all countermeasures that we use in health emergencies. We are working with the different sectors, including the private sector, so that we can have all these enterprises for manufacturing of the different items to not only start, but also to grow and be the point of supply for what we use and what we need here on the continent of Africa. So these are my three messages today on COVID-19 vaccination, on Ebola virus disease outbreak, and on local manufacturing for health security of the continent. Thank you very much. Back to you, Nick.
Thank you very much, Director. Sorry, it's the use of technology. Very clear and succinct message to our colleagues. You already have your headline points, and we also want to say thanks to our colleagues. And again, apologize for starting a little late today due to engagement that we could not change because of the timing. But however, we made it that we got this very important information to you for sharing with the population. Let's do this next week, same time, this time our 12 o'clock time on Thursday as our regular briefing time. Thanks to our colleagues in the background, both Africa CDC and the AU Commission. Of course, our interpreter who has been providing other language, the opportunity to get the information for the other group of citizens in that segment. Thank you, Director, for making the time, and goodbye from all of us here at Africa CDC. Let's meet next Thursday. Bye-bye.